Hi. Thanks so much, Dana, and Ed, for inviting me to the meeting. I'm sorry that I'm too chicken to travel when I need a test to get back home, but at least we can do this by Zoom. I assume you can see the slides, right? Someone nod. Okay, good. Thanks a lot. So I'm going to talk about the latest and greatest thing, which is whole blood for trauma resuscitation. But first, a little talk about why it's important to use blood products as early as possible in resuscitating trauma patients, even in the pre-hospital phase. And here are some disclosures that I need to tell you about on the background of a snowy Pittsburgh day. So there have been a bunch of studies that have looked at why it's important to use blood products pre-hospital. This was a U.S. military study of 55 transfused pre-hospital casualties. Most of them received just red cells, but some received red cells and plasma. And you can see that there was a 74% reduction in 24-hour mortality if the patients were transfused within 36 minutes of injury, which corresponded to 15 minutes after the time that the helicopter had arrived. So if the patients didn't receive a transfusion, or if they received it in a delayed fashion, there was a much greater chance that they would die within 24 hours. And in fact, giving the transfusion resulted in a 14% absolute risk reduction in mortality. And that's, of course, pre-hospital. This was our randomized control trial where we asked the question, does supplementing whatever the helicopter basis standard of care might be with 2 units of plasma save lives? And you can see that starting around 3 hours and continuing for 30 days, adding 2 units of plasma improved significantly the patient's overall survival rate when it was administered in the helicopter on the way to the hospital following the trauma. Interesting that we did a subset analysis of patients who received different components, and you can see the patients who received red cells and plasma had a 62% reduction in 30-day mortality when they had not only the plasma, but the red cell, and that's basically 2/3 of a whole blood unit. Here are the patients who received the crystalloid, the dotted line, and they had the worst survival because crystalloid is bad for a variety of reasons that I'll tell you about in a moment. So I'm giving you the sense that pre-hospital transfusion is a really good idea and that it helps to save lives. And then along comes the refill study, which was just published in Lancet Hematology from the UK. They randomized adults who were in hemorrhagic shock following a trauma to get either 2 units of red cells with lyophilized plasma or saline. And the composite outcome was either episode mortality, which means they died sometime between their accident and sometime in the hospital. So at any point, 2 weeks into it, 3 weeks into it, 5 minutes into their hospitalization, at any point did they die, or did they have a 20% reduction per hour in lactate? Now, everyone knows lactate is a very important marker in trauma. It's a marker of tissue perfusion, but does it really need to be that important that it's part of a composite outcome? They thought so. And so when you looked at their analysis, you can see here that according to this design, giving red cells and lyophilized plasma does not decrease the composite outcome. So episode mortality didn't decrease, or the failure to decrease lactate didn't decrease compared to giving saline. And the authors quite, I think, boldly conclude that saline is just as good as blood products based on these data. But if you look more carefully at this study, you'll see that if you looked at a much more relevant time point, which is like 3 hours, 1 hour, 6 hours, these are the relevant time points for measuring the very first intervention that we give to patients in trauma. You can see that there was a 6% reduction in mortality for the patients who received a transfusion. Didn't reach significance because it wasn't powered for it, but I think we can agree for something that happens so frequently, which is hemorrhagic shock, a 6% reduction is really important. And it didn't reach significance, I think, because it wasn't powered for it. Also, if you compare the injury severity score, which is a marker that you can only get after the fact, after the patient's been admitted, so it's not available up front, but if you look at it afterwards, the patients in the refill study were like 50% more severely injured than patients in our helicopter study or the proper study, which measured randomized trial measuring to plasma to red cell ratios. So the really injured patients, and the overall mortality in the refill study was like 50%. So half of the patients died in this study. So these are really severely injured patients, and it's hard to imagine what you could give patients who are this severely injured to help them survive. To make a comparison, the mortality was almost half in our helicopter plasma study and in the proper study. So I think what this study is doing is defining the bounds of where plasma or blood products are going to be useful. If a patient is really severely injured, nothing is going to save them, not even blood products. In fact, it took them an hour from the time they were notified about the injury until the time they made the first intervention. So if an hour goes by and nothing happens, that's an hour a golden hour, if you will, that wasn't effectively utilized. And also, I thought it was interesting that they provided us with the average quantity of red cells and plasma that were transfused, but they didn't give us any measure of variation. So did patients get fewer than 1 unit of red cells or plasma, more than 2 units? It's hard to know because they didn't give us a measure of variance. So maybe the patients just weren't getting enough blood products quickly enough. So I mention this only because it's out there and you'll come across it, and you need to be aware that it is methodologically quite limited. So what's the point? So yes, there is level 1 evidence for administering pre-hospital plasma. I think whole blood will be better, and there are at least 3 trials that are underway or soon to be underway evaluating whole blood versus components, or whole blood versus standard of care. Red cells and plasma clearly was the best product to give in our trial, and crystalloid is inferior to any blood product. And you can argue why you give any crystalloid, right? If you give crystalloid, you get a little blip in the blood pressure, it goes up a little bit, that's great. And then as soon as all that volume enters the tissue becomes edematous, becomes swollen. It's very difficult to affect healing with swollen edematous tissue. And for what? As soon as the crystalloid exits the blood vessel, its effect on increasing the blood pressure is gone. So if you look at the Army TCCC guidelines, they don't recommend giving any crystalloid. They want blood products used at the beginning, and if there aren't blood products, then you find some. They don't give any facility for using crystalloid. It really is that bad. Nothing normal about normal saline. It's a joke that someone called it normal saline. But so this is where we stand. This is where the evidence is at the moment. So what about low titer group O whole blood? Why would you want to use low titer group O whole blood? And the question always comes up about what is a low titer, and that's up to you to define. But probably anything less than 256 in terms of anti-A and anti-B will be fine based on our knowledge of incompatible platelet transfusions. I'll show you some data from Pittsburgh. We use a titer of 100 now, perfectly safe, but the Red Cross uses less than 200, that's fine. The U.S. Army uses up to 256. I think that those titers are suitable. There are many advantages of using whole blood. Primarily, it simplifies the logistics of the resuscitation. When people go out for a night out, when they're going to drive, they don't put in a large bore IV in both arms just in case, right? If you have a trauma casualty, often you only have one access point. And so what product are you going to give first, the red cells or the plasma? Using whole blood gives balanced resuscitation right up front. And that's really important. We talked about ratios in transfusion, and I don't know what the optimal ratio is, but I know that an imbalanced ratio, especially up front, is very bad for the patient. So when I talk to surgeons, I hear a lot of them say, I'm getting the MTP, massive transfusion protocol, I'm getting the plasma, platelets, and red cells, and I'm giving it so the patient gets balanced resuscitation. I don't need the whole blood. Well, that's what we thought too. So we did this study at our pediatric hospital, and we asked the question, how long does it take to get just 1 unit of plasma, of platelets, and red cells? And if you give whole blood, that's the solid line here, it happens very quickly, because as soon as you start the whole blood, that's balanced resuscitation. But look how long it can take to get just 1 unit of plasma, platelets, and red cells in our pediatric patients where an MTP is available. It can take hours. So these patients might have had 10 red cells and 2 plasmas and no platelets, and it might take 500 minutes to get just 1 unit in. And that's not balanced resuscitation, and that's not helping the patient. So with whole blood, balanced resuscitation is provided up front. You get cold store platelets, which in vitro, in laboratory testing, look really good. They look primed. They look ready to cause clotting. Certainly, they outperform room temperature stored platelets, conventional stored platelets in these tests. But these tests don't correlate to in vivo bleeding. What is the ultimate test that we use to show that platelets actually, or the platelet function leads to reduced bleeding? We don't have it. But for the tests that we do use, cold stored platelets certainly outperform. And there are a variety of randomized trials that will show us if cold stored platelets really are better than warm temperature platelets. Of course, whole blood unit is more concentrated than components because we don't have to add the additive solution to the whole blood like we do to the red cells. Reduces the risk of mistransfusion because it's a group O unit. We keep it in the refrigerator, so there'll be less risk of bacterial contamination. And I think this is really cool. It makes platelets available where they might not have been. So if you're at a remote skiing village or somewhere where people sometimes need transfusions because they crash and break their acetabulum, you're unlikely to put platelets there because you'd have to keep rotating these things every few days to maintain a viable inventory. Well, with whole blood, you can have platelets for beyond 5 or 7 days. You can have it for 21 days or 35 days, depending on how you collect the whole blood. They might not be functional for the whole time, but at least they're there and can get the patient through until you can get them to a more definitive care hospital. And of course, very easy to transport and reduces donor exposures, which is always good. So what's the evidence for using whole blood? In one word, it's not great. And that's because it's only been studied in primarily observational ways. So this is a paper that we just published where we looked at all of the different studies on whole blood. One of them was an RCT, but it was modified whole blood. It didn't have any platelets in it. They were filtered out. All the other studies were either prospective or retrospective studies, small numbers of patients, in many cases, small numbers of whole blood units that were transfused. But interestingly, there were a bunch of trials on pediatrics. So the use of whole blood in pediatrics is increasing too. And in general, this is what we found, was that some of the studies showed a benefit of whole blood early on, such as arrival to the emergency department or emergency department survival. And I think this is really important because I think this is what we can expect out of whole blood, is to get the patients to the hospital or at least through the emergency room early in their treatment alive. And then the rest of the treatments can be evaluated after that. So it's really not a surprise that most of the studies did not find any difference in more long-term survival, like 28-day or 30-day survival or in hospital. But interestingly, when we looked at other clinical outcomes like sepsis, multi-organ failure, kidney failure, a variety of things like length of stays in the ICU, we found that the whole blood patients didn't do worse than the component patients. So it's not like we were inducing extra clots or causing people to spend longer times in the ICU when they receive whole blood. So I think the best we can say from these observational data is that the whole blood patients certainly don't do worse, and it makes the surgeon's life so much easier to know that they're giving balanced resuscitation early while we're waiting for the ROTEM or the TEG results to come back, and when we can provide a more personalized transfusion experience. So how do you do this? You can implement whole blood at your hospital once it becomes available, of course, from CBS. And anyone who likes motor racing will recognize the FAF car that won the Daytona 24-hour race this year. Of course, if you don't like racing, you'll have no idea what I just said. But it's very, whole blood is really becoming far more increasingly used in American level 1 trauma centers. That's the black bars here. You can see in 2018, we got the ABB to change their standards so that we can use group O, low titer whole blood, for patients whose blood type we don't know. And after that, the use of whole blood has been increasing. In fact, in our survey, we found that of the 103 level 1 trauma centers that responded, 42% were using whole blood, and an additional 14 were going to start using it as well. So that's almost 70% of the respondents that we polled either did or will soon be implementing whole blood, and more than half of them will use an Rh positive whole blood unit for females with childbearing potential whose Rh type they don't know, which is a safe practice too, but it's a topic for next year when I'll be happy to visit Vancouver without needing to test on the way back. Hint, hint, Dana. So how did we do this in Pittsburgh? Well, we started in 2014 in December using whole blood. Initially, we started to give it only to male trauma patients who were hypotensive, or for women over 50. But we've recently dropped the women over 50 criteria. So now any adult, male or female, can receive whole blood, regardless of their RH type, as soon as they get to the hospital. We started with 2 units of whole blood because we were one of the first centers. We wanted to be conservative and not have, and to just kind of see what happens to these patients. Was there any hemolysis? And now that we have 7 years under our belts, we're up to 8 units of whole blood now, which we keep in the emergency room refrigerator for immediate use. We want this to be the first product transfused to the trauma patients. After that, conventional components, but that's fine because by then we'll know the TEG results and we'll know how to properly resuscitate these patients. Plus, we use 2 units of whole blood in our MTP. The whole blood units are RH positive, which we collect with an inline platelet-sparing leukoreduction filter. We started with a titer of less than 50, but we needed more whole blood because it really caught on, so we switched to a titer of 100. I'll show you that's safe. We titer every donor every time in case somebody starts taking yogurt or something that causes their titer to go up. We don't want the person with a titer of 1,000 to donate whole blood. And we use only male donors to mitigate the trolley risk because that's the easiest thing to do. We keep the whole blood as whole blood for 14 days, at which point we take it back and we can make a red cell that's O positive and leuko reduced and very easy to use as a cost mitigation strategy. And so you can see since 2014, we've had about 2,500 recipients of 5,500 units. You'll see a lot of patients still get 1 and 2 units of whole blood. That's because the patients will come in hypotensive with visible marks to indicate bleeding, like a bruise or blood. And so they'll be hypotensive. The presumption is that they're bleeding from hemorrhage. So you don't want to get behind in those patients. So they're given the whole blood. And when they realize after the CT scan comes back that the bleeding was neurological that the hypotension was neurological or from some other cause, they'll stop using whole blood. But that's not a waste. That's not an inappropriate transfusion because getting behind in these patients is such it's a compromised position and it's difficult to recover from that. So we'd rather use a couple of whole blood units and turn out that the patient didn't need it than the other way around. Here we were talking about the safety of whole blood. We measured the bilirubin, haptoglobin, and LDH of adult trauma patients who received at least 4 units who have a titer that was less than 100. And you can see that there was no significant difference in the biochemical parameters, except a couple of times here where the bilirubin was a little bit higher in the non-group O recipients. So this is the AB and AB recipients who might have hemolyzed, but you can see that the bilirubin titer or quantity is still within the laboratory's normal range. And by day 3, it came back to normal. So we don't worry about this. This to us is good evidence that there's no evidence of hemolysis in these adult trauma patients of a substantial quantity. That's 2 liters of whole blood. We do whole blood for the pediatric patients as well. We started this a little later. Both the boys and girls get trauma, they get trauma and then they get whole blood when they get resuscitated. For them, we use O negative whole blood because we have enough to supply them with O negative whole blood, group O, of course. And again, we started with a titer of 50. In the local vernacular in Pittsburgh, they would say 50. I kid you not. And then we upped it to 100 because we just didn't have enough whole blood. And again, when we started the program, we put in some very arbitrary guard bands, like the kids had to be more than 15 kilo and more than 2 years of age. We wanted them to have enough A or B substance to neutralize the anti-A or B that was passively being transfused. We realized that wasn't an issue. So now we're down to just kids that have to be greater than 1 year of age. And soon we'll drop that as well. And they can receive up to 40 mils per kilo, which is about equivalent to 6 units of whole blood in a 70 kilo person. So it's a lot of whole blood, and anyone virtually can get it in Pittsburgh. We keep the unit in the refrigerator as well for the emergency use. And if you think that there's any problem giving whole blood to kids, there isn't. Here we have some data with a titer of less than 50. And you can see, again, no difference in any of the biochemical parameters, creatinine, potassium, any of that stuff. No hemolysis in the kids. Perfectly safe to do. And lastly, I just want to mention this one slide here. Some people are afraid to give blood products pre-hospital because they're afraid that if you give Group O units ahead of the patient receiving a type and screen or having a sample drawn for a type and screen, that it will invalidate the type and screen, that we will not be able to determine the patient's ABO type. We'll have to keep them on Group O red cells forever. So this was a best study that we did of 700 non-Group O trauma patients who received at least one Group O uncross-matched unit. And you can see in 96% of all the cases, we could accurately determine the ABO type. Even patients who received more than 10 units, the median was 12 Group O units, like I say, what's this? 85% of these people had a valid ABO type after the first unit that we received in the blood bank, and this is after they received more than a unit, more than a blood volume of Group O red cells. Our reagents are so good that giving a couple of units of whole blood or red cells in the field before they get to the hospital is not generally going to interfere with our ability to determine their ABO type and provide them with cross-matched ABO identical units when they get to the hospital. So not a good argument not to give pre-hospital blood products. So in conclusion, there is data now that adding plasma to other blood products clearly saves lives. Whole blood is very easy to transport and administer, and it improves outcomes for sure. It is collected at blood centers every day near you, and you can implement its use at your center once it's available in Canada, which I understand is coming shortly, I hope. And so once again, thank you again for inviting me to talk about whole blood. This is called Light Up Night in Pittsburgh, where all the buildings leave their lights on at night, and you get fireworks, so it's pretty to take pictures of that. So thank you again. I know I've gone a bit over time, but I'd love to take any questions that you have. Thank you.
Thanks very much, Mark. Questions in here? I think Wayne's got his hand up.
Thank you, Dr. Yazer. That was a great talk. I'm more interested in the storage side of things, so I'm going to ask this question. I know that the whole blood, low titer GoPro whole blood is being stored at 4 degrees. Can you comment on the interaction between red cells and platelets that is in the whole blood and how that storing them together will affect the outcome? We study the components individually quite a bit, but I don't think we've ever had any data on them being stored together.
So I can answer that two ways. One is there is a very extensive literature of the platelet function in whole blood itself. So whole blood units are the source of the material. Platelets are aspirated from there. Most of this is done either in Norway or in Colorado. And again, comparing those platelet functionality for what it's worth to room temperature platelets, the cold store platelets perform better in the in vitro tests. Again, I don't know what that means for the patients. That's why we're doing randomized trials for patients. We're also doing a study now looking at the supernatant, right? So at day 14, we take the whole blood back, we make a red cell, and we have the supernatant that we just throw out because we don't know what to do with it. We're analyzing what's in that supernatant, and it turns out there's a whole lot of microparticles and nanoparticles in there. And so this looks like a very hemostatic product that we're just throwing out. And it may well be a suitable product for transfusing massively bleeding patients. So stay tuned for that. Thank you.
Thank you.
Yeah, I have a question about the whole blood in pre-hospital transfusion setting. You spoke about the O red blood cells and no problem with typing, with ABO typing. But do you expect with whole blood it's going to be harder to get the ABO typing?
Mais non, I don't think so at all. Because the issue was, would the red cells interfere? Would it cause a mixed field pattern? And that means that sometimes you pick up a little bit of unagglutinated group O cells and a big chunk of agglutinated A or B cells. That does happen, yes. Mixed field does happen after receiving some units of whole blood. But if your laboratory is comfortable interpreting what mixed field means. Like if you know, because you were told by the emergency room, this patient received 2 units of whole blood or group O red cells in the ambulance, you know where the group O red cells came from. And so you can explain the mixed field and you can interpret the blood group appropriately. So if you're comfortable with mixed field, then you should be comfortable with this. The plasma we found had no similar effect on the reverse typing. So there was only a little bit of interference on the forward type, and it's easily explicable. Merci.
So, Mark, there's a question that's come out of the ethers to our electronic website, and it says, "Did I understand you to imply that giving Group O positive units to adult females does not provoke an anti-D response?"
Can I have the next 3 hours?
I couldn't figure out how to put my.
Yeah. So listen, the short answer is the rate of D-allo immunization in healthy people is about 80% or more. In sick patients, it's probably between 20 to 30%. So there is a smaller chance of D-allo immunization. But if you calculate everything that has to happen between surviving the trauma to having a baby affected by hemolytic disease of the fetus and newborn, you'll see that the overall risk is a fraction of a percent. And when you put that in balance with the 14-15% absolute risk reduction in mortality that giving blood products confers on the recipient, to my mind, it's a straightforward calculus that you would provide the Rh positive whole blood units to patients who are bleeding. If you can provide Rh negative units in the pre-hospital setting, by all means do it. If you have enough Rh negative in the ambulances and the helicopters, use them. That's great. That eliminates the risk. But most places are not in that luxurious position, and they have to make a choice between using Rh positive units or nothing. And I would argue strongly that using Rh positive units provides a minor risk of HDFN and a very significant risk of survival. And please email me, whoever that is. I would love to send you all kinds of data we have on that.
Okay. I think Dr. Schubert has a question.
Thanks, Mark, for your great presentation. My question would be, do you have, or what is, in your opinion, the choice of the anticoagulant the whole blood is collected in on the clinical outcome? Because I think in the literature, at least from an in vitro perspective, if you look at the later storage and 35 days, there's not a huge difference. I'm just wondering if you can comment on a clinical impact on the choice of anticoagulant.
Yeah, vielen Dank. The choice of anticoagulant is really going to depend on how long you want to have red cell on the shelf. We have 21 days because that's the CPD, that's what comes with the leukoreduction platelet sparing filter that we want to use because we want a leukoreduced unit. We recognize that platelet function around day 14 rolls off. It doesn't become 0, but it becomes lower. And so certainly by the time day 35 comes, the platelets are not going to be terribly functional by that point. And so you have to accept that that's going to be, let's say, a risk of using platelets, using whole blood that has a longer shelf life. On the other hand, what you get is a longer shelf life. And so you may be able to store it longer. You might be able to reduce wastage. And you might have the products available when you need them. So, if the platelets aren't functional by day 21, they're not going to be any better by day 35, but yet you may have those units available to provide at least red cells and plasma to the patient in a concentrated way pre-hospital.
Thanks, Mark. I think maybe Dr. Prysdale has the last question.
Mark, nice to see you wearing a Team Canada jersey. Thank you. 2 related questions. You're up to 8 units now. Is that in conjunction with tranexamic acid? And what is the state now of clotting factor consumption?
Yes, so we use tranexamic acid where it's appropriate for our trauma patients for sure. Start with a gram and then a push and then another gram administered over a longer period. For trauma patients, Coagulation factor use, like recombinant factor 7A, PCC, almost unheard of in trauma now. We jumped off that ship ages ago after we saw data that showed that factor 7 is harmful in trauma patients. And I think the other thing is that because we're trying to provide blood products earlier in the resuscitation, like way earlier, like in the ambulance or helicopter, we're getting to the patients with factor earlier in the form of plasma. So we're providing this balanced resuscitation earlier, which may well be negating the need for us to use more expensive and potentially dangerous clotting factor concentrates. So we rarely, if ever, use them in trauma.
I was more interested in trauma-induced coagulopathy, in that side of consumption of clotting factors as a pathology, as opposed to using it as a therapeutic. But anyhow, we can talk about that some other day. Thank you.
I'd like to. Thank you.
Thanks, Ed. And thank you, Mark. That was a really interesting talk. I think we'll move on now to our next speaker.